A scientist in Cambridge is working to tackle racial inequalities in cancer research and improve the health outcomes of those from minority backgrounds.
Black men have a higher chance of getting prostate cancer than white men. And data also shows that black women are more likely to be diagnosed with various cancers at a later stage. Musumi Bakshi reports.
Does it matter if you're black, brown, Asian or white? No. Does it matter when it comes to your health? Well, maybe.
Right, okay.
In this laboratory in Cambridge, Sigourney Bonner is trying to change that. The 33-year-old founded Black in Cancer, trying to attract more black students to the sciences while understanding why so many die from certain cancers.
There are actually more people from minorities dying of cancer than there are from predominant or the majority community. So I tried to look into, why is that the case? Why are people from my community and similar communities dying disproportionately? And actually, some of it is really to do with how patients are treated, whether they are diagnosed earlier, and all of these things can have an impact on outcomes. When you are speaking about your symptoms, are they recognised by your clinician, and are those things taken seriously and taken forward?
Where we come from, how healthy or wealthy we are, can all have an impact on certain conditions, inequalities that first came to light during the COVID pandemic. For instance, black communities suffer disproportionately from strokes and diabetes, but here the focus is on cancer. It's why Cancer Research UK here in Cambridge is funding the next generation of researchers and doctors, raising issues perhaps only seen and understood by the black community, like Randy, who lost an aunt to cancer.
When I came to the UK, there was not many black students in the class. And I also didn't have anybody to look up to, any black role models. They were all white or, of other ethnicities, but not black.
There definitely is a underrepresentation, and that's something that I noticed immediately coming to Cambridge, but also having people with diverse backgrounds doing the research, asking the questions to ensure that what we're looking into will represent everybody. I think that's really important.
Who we are and where we come from shouldn't matter. But with so many black women being diagnosed late for breast, ovarian and colon cancers, the work done here could be transformative.
Let's talk now to Naser Turabi, who's from Cancer Research UK. Naser, morning to you. Thank you for coming in. We had some of the detail there, but I wonder whether this is a social problem about things like background and access to healthcare and sort of perceptions, or whether this is a genetic thing, that people are genetically predisposed to cancer in a different way.
Well, actually, it's all those things, in fact. And cancer is a very complicated disease. And in fact, we consider it many hundreds of different diseases. And so understanding someone's genetic predisposition is really important. And that, of course, varies by your ancestry. But it's also really important to understand the experiences of different people. So sometimes it's a matter of different communities, often specific communities, beliefs about cancer. But it can also be about their experience of the health system. And what we've got is a health system that's been under pressure for a long time. And so having that time to care, that time to talk to people is constrained. And some people, frankly, experience that in much more difficulty than others.
So that's a great, simple question to answer to quite a complicated question. Here's another complicated question. How do you now change that when there are so many factors coming into play?
So there's a number of things that we can do. So obviously at Cancer Research UK, we're doing research into this, and we're doing research into the genetics of it and really understanding what are different people's predispositions, what are their responses to treatment as well. That's also really important. So that research and the data that goes along with it is incredibly important. We also need to make sure that services are accessible. And in fact, all of us experience problems accessing the NHS. So improving that is something that will benefit everyone.
And from a social point of view, and I'm interested in sort of not only the backgrounds of people coming, to health services for that treatment, but their perceptions of how the health system can work for them. And it's not only about access, is it? But it's about whether they want to seek treatment in that way.
Yeah, absolutely. And many communities have good reasons to be less trusting of health services and official services generally. And that's something that the NHS and everyone else involved needs to work on. But it's also really important to get information out there and help people understand that. So, for example, we find through research that we've done that there's wide variation in the understanding of the signs and symptoms of cancer. That goes along socioeconomic lines. It could be about deprivation, but we also find that people from different ethnic groups have different perceptions about, for example, the extent to which cancer is treatable. So one really positive story is that over the last 30 years, cancer survival has improved massively. But actually some communities we find from research think it's still a death sentence, and so will be reluctant to go to their GP if they've got the signs and symptoms of cancer, and even sometimes be reluctant to accept treatment once they're in a hospital situation. And so having services that have the ability to, engage with patients properly, really listen to them, and then support them through that treatment journey is something that will benefit everyone, but particular communities especially.
And one of the challenges we've just reported on this morning is, late diagnosis. And we say this so many times here on the programme, don't we? The key with all of this is as early as possible as you can with diagnosis.
Yeah, absolutely. And we get diagnosed in different ways. So, for example, we see that there's lower rates of screening uptake from people with ethnic minority populations, and there's things that we can do about that, and there's things the NHS can do about that. We also see that people from ethnic minority groups report difficulties accessing GPs, which frankly we all do, but we find that people from black and minority ethnic communities find it more difficult, for example, have to go to their GP with the same symptoms before they get that urgent cancer referral. So there's a lot that we can work on.
There's enough change as well. We've talked about this on the programme before, but when it comes to things like skin cancer, for example, there's simply not enough training of being able to identify possible skin cancers on skins of different colours. Is that applicable elsewhere too?
Yeah, it's partly about training, but it's also about the research to begin with. So much of the data that we have is about the kind of majority population. And when you start to need to make conclusions about a diverse range of people, and indeed cancer is so complicated, we really need to understand that diversity even among the majority population. So things like new imaging techniques. I was actually talking to Sigourney, who was in that video yesterday, and she was talking about one of her colleagues who is doing research into imaging techniques, and actually having that diversity in the research group helps, right from that early stage of research, think about those possibilities of making sure that when it finally comes through into practice, that that information is ready for clinicians and patients, so that, for example, skin cancer is diagnosed more easily across the range of different skin types.
And are we at any point ever going to approach a system where perhaps screening is more targeted? Should that happen?
Well, we're definitely moving in that direction. So, for example, screening is already targeted, for example, by age, and the lung screening that's coming through will be targeted by smoking history as well. But in the future, we'll also be looking at genetics. There's quite a lot of research that needs to happen to be able to do that. And actually, as we do more and more research, we'll find out all these different risks. And so understanding all of that is going to provide another challenge. But hopefully we'll get there.
Naser, so good to talk to you this morning. Thank you for explaining that. Good to have you here. Thank you.
Thank you.